and I'm a direct primary care doctor, and this is pretty fun to see people who are interested in DPC, because we don't usually get to see that very often. What I want to do, though, this morning in a few minutes is try to get DPC to grow up a little bit, okay? And I think that'll make sense as we go along. So a couple disclosures. I own a DPC clinic, and so I'm very biased in favor of DPC. And we have physical clinics in Missouri, and we've got virtual DPC clinics in, it was 36 states, I think it's 42 states now. I also started a insurance agency with my friend Brian Link, because we're trying to create solutions for people, and we sell, we promote Sedera, and we have our own plans as well. And then we just started, Brian and I and a couple other friends started a company called Renovation Healthcare, which is designed to kind of bring all these pieces together, okay? So full disclosure, I'm completely biased. I love this stuff, and that's why I'm up here talking about it. My wife would also want me to say that I overgeneralize everything, and so if I say healthcare is terrible, it actually means healthcare is often terrible, and so kind of take it with a grain of salt, okay? So my goal here is to help us understand that free market healthcare and the value-based healthcare world that you'll hear other people talk about, not so much at this conference, but at other more mainstream health conferences, are really two sides of the same coin, okay? And as we try to sell, promote, accomplish healthcare, if we can learn to talk their language and tweak what we're doing subtly, we are a better provider of value-based healthcare than the rest of the healthcare infrastructure, okay? And it completely broadens our appeal, and it allows you to walk in, if you're trying to sell this idea, whether you're a DPC doc or you're an insurance agent who's converted to away from the dark side, or if you're Sedera or somebody like that. If we talk their talk of value-based healthcare, we're gonna win more friends. And that's kind of the goal. So just as an example, this is some data from our company. It's an example. I'm a doctor, so I like case studies. So quick story, this is a 58-year-old lady who came to us. Actually, my mother sent her to us because she was asking my mom which of her meds she should stop taking. And my mom has no idea. And so mom said, hey, you should join Big Tree, which is our virtual DPC company. So she's employed. She's a school lunch lady, actually at the high school that I went to, and she makes about $12 an hour, all right? So she has diabetes, hypertension. She was depressed, but she wasn't getting treated for that. She has hypertension, and she has a couple sinus infections a year. This is the actual amount that her insurance company was contracted to pay for these various services. I know this because we use this case study to get her company, okay? So they were paying $335 for her endocrinology and cardiology visit every 3 months. She would go to primary care once a year for her wellness visit. She would go to urgent care a couple times a year. She had lab draws and diabetic supplies that was costing $115 every 3 months. She was on 3 oral blood pressure meds, which cost $145 somehow. And she was on Jardiance, okay? So she joins Big Tree, one of our virtual DPC plans. It's $44 a month. She initially was paying out of pocket for that. And what we saw was her costs. So, the problem with endocrinology and cardiology, when I was in med school on those rotations, at least half the patients didn't need to be there. And so I remember asking one of the cardiologists, I'm like, why are you taking care of this? I mean, you're a famous electrophysiologist. Why are you taking care of this patient's hypertension? And he's like, well, they're easy visits and I get paid a lot for them. Okay, great. Well, it's $335. So we moved that to our virtual DPC program for all of her cardiology and endocrinology visits. And this is what we have found is the major way we save money for employers, is by moving care to the correct site, which is primary care. So then her DPC, eventually her employer paid the bill, and she went to a local clinic for $52 a month. So then we have a deal with a major lab supplier, which allows us to get labs at about 90% off their list price and 90% cheaper than what the insurance companies pay for them. We own our own pharmacy, and so we were able, in our membership, that includes all of her generic drugs at no additional cost. That's how we play. So our membership, our main membership is $59 a month. That includes unlimited direct primary care and all your generic meds with free shipping, because she lived out of our account. And then we sat down and had a conversation. And I said, Tracy, do you know why you're on Jardiance? And she's like, it's for my diabetes. I said, yes, but you're also taking insulin and a few other meds. You realize if we just increase your insulin dose, you wouldn't need your Jardiance? She's like, why do they have me on the Jardiance? Like, well, sometimes we use it to help lower your risk of cardiovascular disease and diabetics. And for you, it would probably decrease your chance of having a heart attack this year from about 1 in 500 to 1 in 5,000. She's like, so I'm paying $300 a month to lower my risk that much? That's not really worth it to me. It's like, I can't afford my kids. She said she couldn't afford her kids' Christmas presents because she's trying to pay for the Jardiance, right? So we just dropped the Jardiance, all right? So her out-of-pocket went from $388 to $0. And when we look at it on the employer side, the employer's cost went from $285 to just $59. Now that's the power of direct primary care, okay? And it's a relationship with one physician, or we use nurse practitioners and physician's assistants. So one care provider with one patient, and you can make individual decisions that make sense for the patient. So it's patient-centered care, right? Now we're getting a monthly fee for that, right? A simple monthly fee, and then we're on your team. So I often say to employers, do you want me on your team for $59 a month, or do you want me on the other team? Because I'm very good at billing and coding, and I will kill you if you want me to do billing and coding. I spent a lot of money in my previous life getting really good at turning 99213s to 99214s, and I'm smart. I will kill you, all right? So you can just pay me $59 a month, and my creativity goes on helping your patients get better care for cheaper. So what I really think the key to DPC is it's just a mechanism, okay? And this is the grow up time for DPC. All DPC is, guys, is a mechanism to align incentives between the people who need care and the people who are paying for care and the people who are giving the care. That's all it is, okay? Too often when I talk to my DPC friends, it's about making a better medical practice for them. And it is. It's a way better medical practice. The way we talk at Big Tree is we're not in this to make a better practice for me. We're here to give solutions to patients. Okay, and that creates subtle differences in how you play the game. And so we have DPCs that I know, it's very clear that they're setting up a practice around themselves, right? So they don't take calls after hours. They don't allow text messaging, whereas we're doing this for the patient. And so, yeah, we message us 24/7. You need to get in today, we'll see you today. So, all right, so that's DPC. Ready? Okay, now, I'm gonna flip your brains. How many of you guys have seen this slide before? So that's awful. All right, you guys should feel ashamed. Just kidding. So this is the HCP LAN, which is the think tank that came out of the ACA. Okay, and this is their framework for advanced payment models. So if you want to talk outside the free market healthcare world, this is how those guys think about how healthcare should evolve. All right, now they have 4 levels. Level 1 is regular fee-for-service healthcare. Level 2 is fee-for-service with links to quality. So I'm a pediatrician, so if you give more kids their vaccines, more kids are up to date, you get a bonus check, which I know how to game, so don't do that. Category 3 are mechanisms with shared savings. So this is where most people play, right? Some sort of shared savings, potentially shared risk. But then the holy grail, the place where everybody wants to go, is this level 4, all right? Which is population-based payments. Population-based payments are the best way to align the incentives of all the people on the team. Now, why is no one doing population-based payments? There are a few people out there doing it, but almost no one does it. It's because they're all built on that fee-for-service architecture, right? You try and get them to do a population-based payment and they freak out. And so we can't get brokers, we can't get TPAs, we can't get employers to think in a way that actually gets them better healthcare because they're locked into this fee-for-service architecture. All right? So this is like the guys, the think tanks that decide what healthcare should look like in the future. This is their model, okay? And this is also from their work. So the current state, you've got a huge number of people in category 1, a few people in category 2 and 3, and what they want to see happen in the future is an evolution where nobody's fee-for-service, and they push more and more people over to that category 4. But nobody knows how to do it. Nobody knows how to take that large health system and convert them from their fee-for-service world that they know to something that they don't know how to do. Well, guess what? We know how to do it, right? We weren't built on a fee-for-service architecture. And we as DPC, we as Oklahoma Surgery Center, we as the people in this room, we actually know how to play the game that they don't know how to play. But so often we're talking in terms of free market healthcare, which I love, okay? But they're talking a different talk, but we're actually saying the same thing in different languages. So what I'm trying to do here today is get you to flip the way you talk about this, all right? And that's the innovation. So let's talk about innovation. The innovation is do what you're doing, just talk in their language. You see what I'm saying? So when you look, if you read that whole paper, Category 4A includes condition-specific population-based payments. And the examples they have on this slide are PMPM payments for specialty services like oncology or mental health. If you actually read the paper, it includes PMPM services for primary care. Well, that's DPC, right? As long as DPC plays patient-centric, that's us. That's how we know how to play. Now, so what happens then is, if you have a health plan, let's say you're an employer with 1,000 patients and you've seen the light, right? You've taken the red pill as you've been here this week. How do I put this into play? You can completely flip your health plan to a level 4 population-based program just by using DPC. You drop DPC in and instantly you're level 4. If you go to your local health system and try and get them to play ball with you, they're going to be like, well, is this a 992 and 3 or is this a 992 and 4? And did you put the correct modifier on that to get paid correctly, right? And again, if that's how you want me to play, I'm creative and I will beat you. Otherwise, you can just pay me a monthly fee and you get all of our creativity on your team. So what's that look like? When you're paying for visits, I upcode, all right? I'm good at it. We learned in my practice that if you ask the parent if the child was in daycare, you could automatically bill a 992 and 4 instead of a 992 and 3. Okay, it didn't matter if they said yes or no. All right, if you just asked the question. In fact, if you had a form, if they checked the box and said you reviewed the form, I got paid an extra $20. It's a great deal for me. Is that how you really want me to think about the world? Or do you want me to play on your team? Also, if you're a parent and you call me at 4 o'clock in the afternoon and you say you think your kid has an ear infection, I can be there at 5, I'm gonna get $40 for that visit. I don't wanna stay past 5. So I dump them on the ER. Now, if it's a DPC relationship and I'm trying to keep you happy, then I'm gonna stay, right? Because I know if I don't see that patient, you're gonna tell your employer and you guys are gonna dump me. So, yeah. When I was in med school, I never got this. They said, you need to tell your patients they can only address one problem per visit. That was actually taught in my medical school, all right? Why? Right? Because you have to go fast. So when I was a general pediatrician, I'd see usually about 42 patients a day. On a good day, we could get into the low 50s, all right? And I'm also seeing patients at the hospital, right, ahead of that. So I'm basically working from 9 to 5, do the math. That's very fast. I don't have time to address so we have all these systems in place to bring you back for more visits. Why not? I get paid for those visits. So we want you to come in as often as possible. Whereas in a DPC, you're paying for a relationship, not a visit. And then if I need to solve some of those problems over text message, if I need to solve on video, if I need to solve them wherever, we can just do whatever's appropriate. All right, so one of the issues we always come up with, so this is the objections time. All right, Wheeler, makes sense, but I need to see metrics. I want you to be able to feed me some spreadsheet, and this is usually a broker talking. All right, first of all, again, I can make up whatever spreadsheet you want and make it look pretty. So that doesn't actually do anything. And usually what they want to see is something like a process metric. 84% of diabetics had an A1C and done the last 6 months. All right, now, if you go back to that HCP land, they talk about this on how you provide accountability to people like me. The lowest level is a process metric. Did you get a test done? A better way is an outcome metric, which is 72% of diabetics have an A1C under 8.5. Okay, that's better. But outcome metrics too are problematic, right? Because an A1C of 8.5 is actually not that good. And if I'm only incentivized to get you under 8.5, then I want to find all the people with 10s and drop them to 8.5, but all the people with 8.4, which is still bad, I don't want to touch because I need to be spending my time on the 10s. So it also creates perverse incentives. The best way is patient-centered metrics. You survey the diabetic and say, are you happy with your diabetes care? And guess what? That's the easiest way to do it too. So what we do is we provide patient-centered metrics. So we survey our patients. Were you able to get in when you needed to get in? And the brokers and employers we talk to don't want those. They want have the diabetics have their A1C done. But you see how that's an inferior metric. So again, we need to grow up and say, yeah, we have, you guys in this room, you have a better solution than the things that are being sold out there. And so you can walk in and say, oh yeah, we don't use the process metrics like those other guys do. We use patient-centric metrics. I can't believe they're still doing that stuff. Okay, that's how you guys you're holding in your hands the ability to fix healthcare, and I think we don't realize it. Okay, so last piece, the other thing this really helps with is steerage. Okay, so if you've come up with some brilliant system to pay for specialty drugs, and the patients don't want to do it, you fail, right? Now, if you have DPC in the game and you coach us, hey, we're doing this thing for specialty drugs, when we say it to the patient, hey, you should do this for your specialty drug, they're like, oh yeah, my doc said to do that. Of course I'm going to do it, right? Or if you say, we want to implement the Oklahoma Surgery Center, have people travel for their knee replacements. If the broker and the HR person tells the person that, they're going to be like, I don't know. If I tell them that, it works. That's not fair. It's not necessarily smart. It's the way the world works, and we can help you get steerage better. Okay, so again, you drop us in, fixes the whole healthcare system. Okay, so how do you do it? Number one, find a local DPC. Okay, if you're in Arizona, talk to Kendrick, and he can set you up. All right, there are people out there. You want to make sure that they're willing to play ball with you, and make sure that they're patient-centric, but find a local DPC, all right? Now, of course, I'm big tree, so I'm going to promote myself. They're the corporate DPCs. I'm going to talk about us and not my competitors. There are others like us, of course, too, that you have a group of 400 in Toledo? Yeah, I can have you a clinic there in 2 months. Let's do it. All right, who are willing to scale. And that's kind of our thing, is we're willing to scale DPC. There's virtual DPC. So we have the ability to be we're live in 42 states. So if you've got an employer of 10 people in Alaska, yeah, we can do that right now. I've got a provider in Alaska who can take care of them. It's usually cheaper, and we could have a talk some other time about virtual versus in-person DPC. It's different. Okay, but it is a solution that is necessary in certain places. And then you got DPC aggregators, okay, who are DPCs. There's a company called Equal that we're friends with, who you can feed them your patient population, and they will assign them a menu of DPCs across the country. Okay, and they get a little PMPM for doing that. So My time is up. I will hand it off to you next, Adam.
Thank you, Adam. And this is the first I've seen of free beer at the booth. So I don't know why you held that back till Saturday morning, but
it's there. We got tickets.
Thanks. Hi, everybody. Adam Habig, another Adam. I'm sandwiched between two great physicians. I am president and co-founder of Freedom HealthWorks. Not a physician. I have no clinical background. I studied finance at Notre Dame, and I'm a licensed attorney. The saltiest of the earth, I guess, from our last presentation, right? I'd like to talk about the headline today of this presentation is direct care, innovation, and entrepreneurship. And I'd like to show how innovation is really driving entrepreneurship in this space. So free market innovation to the rescue is the title, and it's how entrepreneurial docs are modernizing healthcare. So I wanted to show this slide, and this is interesting, and everyone should take note of this. Was asked to sit on a panel at one of the nation's largest med schools about a year and a half ago. And the topic of conversation over lunch was this notion of a debate between free market healthcare and a single payer system. And I know I'm preaching to the choir here, but it's good to note that the room full of really the next generation of doctors, when they look at the system today, they universally, show of hands, who thinks the system's terrible? Every single one of them put their hand up. And I said, well, don't forget the law school's just down the street, guys. Why are you here? Honestly, come on. But, they say, look, it's a terrible system today for all the reasons we talk about, right? I said, great. So where do you think we are on the spectrum? If you look at this as a linear spectrum, from a free market healthcare system, which really is a thriving marketplace of these clearly priced options, wide variety of decentralized choices for consumers versus one size fits all, where do you think we are today, guys? Their perception is that this is, the mess today is a result of the intrusion of capitalism or the corruption of the system that could be. I said, no, you guys need to recognize where we are today. This is where we are today. You're one notch away from this single payer system. So if you love the way it's going, by all means, let's keep going that direction, right? Kind of an eye-opener for them. The point is, if you're not convinced that direct care and the models, the innovation that come with that are a real, a step forward in the space, you probably wouldn't be sitting here, number one. But at least buy into the fact that if you're a John Stuart Mill advocate of utilitarianism, it does convey the greatest good to the greatest number, and it does that by bringing prices down to the point where most people can afford them. Why does every household in America, nearly everyone, have a flat screen TV on the wall today, right? Didn't happen overnight. It wasn't because some bureaucratic department decided we're going to send out flat screen televisions or we're going to mandate the price of flat screen televisions. No, it's because the forces of the market brought prices down to where nearly everyone can afford them. Same thing with that cell phone. Within this decade, we're going to reach really a watershed moment in human history. Nearly every one of the 7 billion souls on this planet will be connected to this greater consciousness we call humanity. And it will be done through that cell phone, through the power of capitalistic free market enterprise. The profit motive is driving that. It's incredible, the power. So again, if you're not a real advocate of direct care or you're not familiar with it, know this, that at least you should be embracing the idea that solutions and alternatives and choices are good. And so that's what we're going to talk about today. How we bring alternatives to the marketplace. And again, how innovation is spurring that entrepreneurship that is increasing those choices on the really the supply side. And so to reduce this to an economic argument, if you're an advocate of supply side economics, you think, okay, reducing barriers, usually in the form of tax policy, regulatory policy, reducing barriers results in a greater provision of goods and services at a lower price, enhancing value to society. Well, that's what we're doing, again, on the innovation side of increasing the supply of really direct care practices that are out there. So I like to lead with today's takeaways so you can, take your notes right up front and then zone out for the rest of the presentation, right? Know what we're doing here. Let's be honest with what healthcare really is, what medical care really is, okay? It's a consumer service business. It's been called a lot of things. fundamental right, this, that. It's a consumer service business. Let's just confront that right up front, okay? That's what it is. To succeed, look no further than other successful consumer industries, right? Look outside healthcare to see what it's going to take to really revolutionize this industry that's been stagnant in many ways. It's been insulated from the market forces that have completely revolutionized the way you're going to get a ride back to the airport today. We talked about Uber yesterday. The way when you go home, you're going to flip on the television, and are you still going to look at 6 channels on on the antenna TV? Are you going to have a cable package that sells you 200 channels you don't watch, or do you have a Netflix account? That's the power. It's a consumer service business. You got to look at what consumers want. We heard this yesterday from some of the speakers. Second takeaway, direct-to-consumer care delivers higher value at a lower cost to consumers. Bingo, zero, end of story. We just heard that. We're going to hear more about it. There's no debate there. Innovative business platforms are helping independent physician entrepreneurs thrive in direct care. That's the innovation that is launching entrepreneurs into the space, increasing the supply of these critical services. And in the end, a higher value free market system is emerging as an alternative, right? Featuring lower prices, increased access, and better quality. So those are the takeaways. We're going to see those again at the end. So if you didn't get them down, we'll come back to them. Again, let's be honest with what we are and what we're not. Healthcare is a consumer service business. It is. What drives success in a consumer service business? These things we've heard about. Pricing clarity and recurring revenue in many states. The convenience of on-demand services. Being fully focused on core deliverables. Do one thing, do it well. What are we omitting? Successful consumer service businesses omit these things. They go direct. They cut out the third-party payment. No hidden charges, no surprise bills, right? You get that Uber to the airport today, you know exactly what you're paying before you book it. Bingo. No waiting. It's all about convenience, right? Consumers are busy, they value convenience. And no misalignment of interest. We've heard about that too. So many times in medical care and healthcare, there is this crazy misalignment of interest, right? You've got to be right in lockstep with your consumer to succeed. So here's what the free market demands, right? Consumers, in a healthcare sense, in medical care sense, demand care to be on demand. They desire the advice, the advocacy, the medical guidance from a trusted expert for a clear price. Sounds simple, sounds self-evident, right? The cool part about this is, not only is this what consumers want, it's the way that doctors, and I'm speaking as an attorney from doctors, so this is the way doctors want to practice as well. Unshackled from what we call practice by billing code, right? Open your playbook up. You're not confined to what Anthem thinks you ought to be doing, paint by number style. Having time for follow-up activities outside the office, being an advocate, being what I call a medical counsel, right? There are a lot of parallels with the legal profession, there really are. And medicine should learn from that. Doctors should learn, here's what an attorney does for their clients, even when they don't have the answers in-house. I can't do the work for you, but I'm gonna find someone who can. And I'm gonna be your advocate, I'm gonna be your guide, navigator to get that done. Predictable revenue streams, any business wants that, yes. Manageable patient loads, yeah, to provide the kind of service and the quality that is expected, that's gotta be part of the bargain here. A return to independent practice, I think this is critical. We're big advocates of this at Freedom HealthWorks. The whole thing started because Chris and I watched our parents, both primary care docs, 35 plus years, wrestling with early retirement because they just couldn't pedal any faster on the hamster wheel, right? We said there's gotta be a better way. Just detach the things that are poisoning this profession and leave the rest, leave the pieces you enjoy. That's the wellspring of what we're doing now at Freedom HealthWorks, right? Give doctors the ability to be independent again, to thrive, to have their dream practice. Let us take care of all the objections that get in the way. And then a complete alignment of interest. So if this is so great, this is the fundamental question we'll address right here today in the next 10 minutes. If it's so great, consumers love it, doctors love it, why the sluggish adoption? Why are we stuck in this bell curve distribution with, again, just the early adopters that have embraced this model? Where are the rest of the doctors? Come on, guys, there should be a herd running this direction, right? The problem is risk. Any small business, any business involves risk. And in this particular business, there are 3 distinct types we've identified. There's launch and conversion risk. I don't know how to do this. Where do I start? Is it legal? Questions we get all the time. There's business operational risk. Great, I'm in business, my shingle's hanging. How do I run a business? It's not easy. And third is economic risk. What if nobody shows up? Every business wrestles with those components, especially number 3. So the result is it takes a real innovator to want to embrace that challenge and move. And God love them. They're in this room. They're on this stage, right? It happens. Absolutely, all the respect. Question is, how do we get the rest of them? How do we get into that early majority and that late majority of docs, right? How do we get into their part of this curve? Well, we need that innovation I talked about that defrays the risk for these doctors and shows a path to success. So here's the solution that we've come up with. You mitigate these 3 points of risk. You start with a choreographed, guided, and low-stress launch sequence, right? Somebody comes to us and says, hey, I did this, I looked at it on my own. It was gonna take me 3 years and $350,000 to launch this small practice. We go, that's a significant hurdle, understood. Understood. What if you could do it for 10% of that cost in 3 months? You wanna go? Full service operational support. Any small business needs this. Medical practice especially needs this because you're going to be focused, again, fully focusing expertise and talent on the task at hand, saving that life, improving that life in front of you, right? Outsource the rest. Every business does it. We do it ourselves. If you focus on the core few, you outsource the rest, you're going to be in better shape. Capital funding. Capital is the lifeblood of any business, right? This gets in the way of a lot of physicians that want to move to this model. A marketing platform. Again, this question, what if nobody shows up, right? A diverse array of sources of patients, of customers really, that will drive the revenue growth in this practice. Expansion and succession assistance. Some of you have come up and talked to us, hey, I've had great success in this model. We're blowing up. I need help bringing on a partner. Or I'm looking to retire. I want to realize that terminal value in my business like somebody in another industry would realize, part of the gig. And then inclusion in a community of like-minded independent doctors. Again, you're not on an island. No business is an island ever, right? You're part of a community of docs. That's critical to your success and not feeling like you're isolated. So I'm gonna go through these pretty quickly. We call it our FreedomDoc Platform. In a little more detail, each of these 6 steps, launching your dream practice. This can be a bewildering path. It's not always the same path. Like I said, many of the doctors who have experienced success, who've made this transition on their own. And look, we don't care how you get there, docs. Just a note of aside. If you're a DIY proponent and you can get there on your own, great, go. We're trying to bring the rest of the docs along that perhaps aren't that intrepid to see that that's something they want to do. But any way you can get there, go. But we say, look, follow this well-choreographed launch sequence. We've taken best practices. We avoid missteps. This full service operational support really begins before day 1, but it's all about, hey, how do I run my business somewhat on autopilot in the background while I'm doing what I do, right? Which is helping patients. Number 3 is capital for launch expenses, overhead, physician income. How many times we hear a doc saying, I don't want to do this. I'm nervous because I don't want to take out a 3rd mortgage and live on ramen for the next 3 years, right? It doesn't have to be that way. That's not how it has to be in business world, right? But capital is the lifeblood. So we've sourced some capital partners and we're looking at launching really our own capital platform later this year that will provide tailored capital to help alleviate that concern with docs. Proven revenue growth. Predictable revenue growth from a proven marketing platform, right? This is it. This is customer acquisition in any business, no matter what you're selling. How are you gonna bring revenue into the practice on a predictable metric? So we've heard a lot from employers, and we've heard a lot of large employers, small employers sourcing. That's great, we love it. Really, it's an all-above solution. Don't forget just recruiting though from your local community. A lot of consumers want this. And really, when you fill your panel out, you're going to want to see that you've got a multitude of sources for your patients, so no one particular account walks away and suddenly you're completely empty again, right? So 5 and 6 are important. Assistance with expansion and succession planning. Yeah, this is something you hope to worry about someday, right? Right? When you filled your panel, now I'm going to bring on a partner. These are great problems to have, as we say. But nonetheless, they need to be considered. Any business, if you're successful at some point, you'll reach this level where, yeah, it's time to grow, or it's time to get out, and it's time to realize some value for your hard work over the years in building something with value. And 6, security and inclusion in a widespread, mutually supportive community. This community already exists. The FMMA is such a community, right? This is really speaking to physicians who are now, they've become independent again, and perhaps there are elements of being part of a hospital group or part of a larger medical group that they miss. Just trading notes with other docs in the coffee room, right, in the lounge. This replicates that in a way and allows them to still trade notes, trade information, and have that camaraderie. So those are the 6 elements, and what this will do in our theory, I suppose, is that I mentioned alternatives, and this could very well be the future of what we see. No crystal ball, but you've got this traditional insurance-driven system we all know and love today, right? Doctors must serve the people who sign their paychecks, like we all do, and insurance is the primary currency used to purchase care. I think it's the wrong currency in many, many cases because it leads to these barriers that arise. Unknown pricing, narrow networks, inconvenient access. What if right next to it there was this alternative system that emerged? And it is emerging, we know this. I mean, we've been talking about it all weekend, right? It's emerging now. But there's a time in the not too distant future when this end-to-end system sits right next to the system we have today. And I think looking at those, you can tell which system consumers, those that actually have dollars to spend, are going to choose. Transparent pricing, doctors serving their customers who are patients, and then insurance as a safeguard against expensive catastrophic events. I use insurance in air quotes, right? Insurance is nothing more than a financial instrument that protects against catastrophic economic events. So that's a loose term. That's not a term of art in a legal sense. This is what it might look like, and we believe that that direct primary care piece could be the centerpiece. But the solutions to this, to bringing this to life, direct medication dispensing, direct care specialists, how many of those have we talked to this week? Direct ancillary services, complementary insurance, in air quotes, coverage, value-add services. This is it. This is healthcare. This is the alternative system that can emerge, the consumer-friendly alternative, right? The key is we need more of it. We need it now. And that's I guess the punchline from this, right, is how do we get this, increase that supply, right, in the direct care space of the physicians, of all stripes. We talk about primary care a lot. It certainly has expanded beyond primary care. It's really this entire ecosystem right here. This is the direct care ecosystem that is right at our fingertips. And there's enough expertise in this conference this weekend to make this happen. It's going to come true. This is a map of the freedom, we call them Freedom Docs, the folks we work with across different specialties, a lot of primary care, but also others. And this just is an illustration. It's becoming a reality. As these map dots continue to fill in, it becomes more real. Last thing I'll say, we'll revisit those takeaways. Remember that healthcare, medical care is a consumer service business, whether you like it or not. It is. It should borrow those tactics, those strategies that succeed in other businesses to succeed. In that realm, direct-to-consumer care, we've talked about it. It delivers higher value at a lower cost to consumers. There are innovative business platforms that are emerging to help independent physician entrepreneurs thrive again. And that's not easy. Like I said, when you look at just the mindset of that class of third-year medical students that I described in that luncheon, a lot of them don't even know this is available. They need to be red-pilled, all right? And then lastly, this is what can emerge, that diagram we just showed. This is what is emerging, and it's this kind of innovation, this kind of entrepreneurship, doctors taking their profession back into their own hands that's going to make it happen. I want to close with a great quote from Sir Winston here. And he always said, you can always count on Americans to do the right thing after they've tried everything else. tongue-in-cheek, but the takeaway there is, let's give the free market a chance, all right? Let's give it a shot. And these entrepreneurial direct care doctors, they're leading the way. So with that, you're gonna hear from one. Thank you.
Good morning. My name is Dr. Lee Gross. I am a full-time practicing physician in Southwest Florida, and I am one of the earliest and longest surviving direct primary care practices in the country. The name of our practice, Epiphany Health, is a very strange name for a healthcare company, but in fact we had an epiphany, and the epiphany was, why are we inserting so many obstacles between the doctor and the patient? Why are we making so many codes and complexities and barriers, and then we wonder why healthcare is impersonal and difficult to navigate? So when Dr. Smith asked me if I'd be willing to come up and talk today and share my story, again, thank you for the invitation, and James and I said, well, I don't know, is Carl Schuessler gonna be there? And he said, yeah, he's gonna be there. I said, I don't think I can rock the pink pants. He's like, that's all right, I'll put you on another panel. I'm like, well, at least make them both Adams so I can remember the names. Thanks, Mom. So, Carl Schuessler, I'm going to talk a lot about our experience today, but I'm originally not from Florida. I'm from Ohio State, or from Cleveland, Ohio. I'm an Ohio State grad, and unfortunately, our Buckeyes probably won't lose enough games this year to play Georgia, but we'll see what happens. We might have a rematch, but we'll kind of see what happens. So, I'm going to go back about 7 years where Florida's trying to figure out our problem with our healthcare crisis. And they reached out, the governor launched a commission, a hospital and healthcare pricing commission, and they invited Dr. Keith Smith to come and testify. And he flew from Oklahoma to Florida, and he gave a compelling testimony. He said, but you don't need to call a guy from Oklahoma to talk about free market healthcare reforms. There's a guy right up the road that's already doing this stuff. He's like, you got to contact Dr. Gross. And so the governor sent his folks down to my office, and they spent an hour in my office, and they're like, this is fantastic. We need your testimony. Can you come and testify before our commission? And so I dropped everything, canceled my patients, drove down, and I gave a testimony. And all of a sudden, I got this phone call out of the blue from some CEO of a hospital about an hour from my practice, which is in Northport, Florida. My practice is in Northport, Florida, Southwest Florida, between Fort Myers and Sarasota. And he said, hey, I was watching this hospital and healthcare commission testimony. I heard Dr. Smith in the Surgery Center of Oklahoma, and I heard about your practice model and what it is that you're doing. He said, and I think we can replicate that here in Florida. He's like, I'd love to work with you with your uninsured patients and see if we can't create some kind of bundles or work on some cash pricing, and let's just see what can happen. So this is a 49-bed rural hospital. It's the second poorest hospital in the state of Florida. So this is not a wealthy community. And this community is used to seeing patients leave the community for healthcare. So anything that can be brought into that community is a huge boom for this hospital. And as many of you know, 100 rural hospitals across the country have shuttered their doors since the passage of the Affordable Care Act due to the overburdensome regulations and the Medicaid stuff is just crushing these hospitals. And when you lose a hospital in the community, you lose the community. So when you have somebody, you have conferences like this where we're sort of bashing the hospitals, and then you've got these guys in these little towns that are just fighting to stay alive. You have to realize that not all hospitals are the same. And this CEO, Vince Sika, really was visionary to reach out to us. And so we created bundles that all of a sudden were drawing patients to this little hospital from all over the state of Florida. And the employees of the hospital started seeing, wait a second, why is a patient from Miami driving past Cleveland Clinic and all these, leaving the University of Miami to come to Arcadia, Florida, to DeSoto Hospital to have a colonoscopy? It's because they have bundled cash prices and there's no surprise bills and they're guaranteed that their pathology is included. They don't get a surprise $3,000 to $5,000 bill in the mail when they have a procedure done. And so we started doing this, we started seeing these patients coming in, and the employees in the hospital said, wait a second, what's going on here? We're used to people leaving, why are people coming? Why am I seeing people from Naples having stuff done here? Well, we had our first hip replacement done. And Vince calls me up and he said, I'm really excited, by the way, it's $18,500 for hip replacement, cash price to be done in this. We sent him an uninsured patient. The guy wrote him a check, and Vince calls me up the day before. He's like, I'm really excited. We got everything all set up. I got Egyptian cotton sheets for the room. We got balloons. It's all set up. We got a catering menu set up for the family. It's really spectacular. And by the way, I hired a private duty nurse. And I'm like, oh my God, that's spectacular. I'm like, by the way, how much does Medicare pay you for the same surgery? He's like, oh, about $18,500. And I'm like, well, why doesn't Medicare get the Egyptian cotton sheets and the balloons and all the stuff? And he's like, because Medicare doesn't look me in the face and hand me a check and this patient's not going to audit me 7 years and take the money back. And so it has a different feel when you got to look somebody in the eye and actually exchange money with them. So after a while of experience with them, I said, Vince, I've been to enough of these things. I've heard and drink enough of the Kool-Aid. I said, why can't we do this with your employee health plan? You're leaving so much money. They were a self-funded health plan, but they were self-funded on a commercial TPA platform. Not mentioning any names, let's use letters like UMR. Don't want to say names, but so they were a 338-member plan, self-funded, and so we tried to work with them to restructure things, and we brought in one Carl Schuessler to kind of work with how we might restructure this plan. And I'm going to go through, we talked about the hows and the whys of direct primary care, but if we're not really full of crap, we should be able to prove that what we're saying is true. So I'm here today to kind of show you some of our data at some of this experience now. We're about 3 years into this program, and we'll see where the granular level, where the rubber meets the road, how direct primary care really can make a difference in one of the poorest counties in the state of Florida with an employee health population. So we sat down with Carl, we sat down with the C-suite team of the hospital, we sat down with the stop-loss carriers, and we spent an entire day in a room building the health plan brick by brick and deciding how we were going to structure this thing. And Carl looks at me and he says, yeah, I'm going to need you to submit me some data. And I was like, oh, hell no. Well, that's what I got away from. I'm not going to start submitting you data. And he's like, no, I need some stuff. I'm like, I'll tell you what, I'm going to submit you one claim. And the claim's going to be, I touched that patient and that's it. And I'm going to give you a code as to why, what I saw him for. So we can do some research and data collection and find out what exactly was happening in this population. But the neat thing that Carl did was he said, okay, we're not just going to pick their doctor for them. They can choose DPC, non-DPC. It's their choice. If they go to non-DPC, they can choose their doctor. They don't have to change anything, standard copays, deductibles, or they can go DPC, but we want to create this plan that steers them to be making better choices for themselves and financially for the plan. And so they gave a 20% discount if the employees chose the direct primary care plan. That was built into it. And the incentive for me was they said, hey, Dr. Gross, if you and your team order any tests, your prior authorization consists of Dr. Gross wants the test. That's it. That's the prior authorization is. The direct primary care ordered the MRI, we're paying for the MRI. Direct primary care ordered the referral, we're paying for the referral. That's the process. So I have no paperwork, no authorizations, nothing whatsoever to deal with these patients. And so he built quite honestly, a really good mousetrap. And this is Carl talking to the employees as we're rolling it out. We spent an entire day, my team and his team spent the entire day explaining this plan to all the employees. So fast forward now, we are now 2.5 years into this. So this data here, I want to focus mostly on, let's see if I can do this here without killing myself. I want to focus on that column here on outpatient. This is a relatively small health plan. So small, one admission to the hospital can really skew data, and one patient on an expensive drug can really skew pharmacy stuff. So, but the vast majority of the stuff happened in the outpatient world. This is the total plan costs. If you see that gray bar, that's the national benchmarks for costs. You see the green bar, that's 2018. The blue bar is 2019 in costs, and this is per member per month. And so you can see both years, the total plan outperformed the national benchmarks. That's DPC and non-DPC combined. If you look at the non-DPC side, again, solely focusing on that outpatient category there, the outpatient side there, you can see, again, meeting or exceeding the national benchmarks on that. But if you look at the DPC side, you're going to see where we're actually starting to drive most of the cost savings for this plan. So you can see benchmark, too much coffee this morning, 2018 and 2019. So we actually did better in 2019, 2020. We did better in year number 2 than we did in year number 1, and both years outperformed the national benchmarks for this population. But so there are a couple things you're going to see here in this data is we had a before and an after. So you had the UMR product, and then you had the independent TPA fair cost health plan with the DPC in there. And then you have the DPC versus the non-DPC. So we have a before and after and a control and comparison group in here. So if we look at the DPC versus the non-DPC here on the cost side, this is per member per month. You can see on that top line here that the plan on the DPC side spent $263 per member per month, and on the non-DPC, $507. The DPC saved 48%. That was paid by the plan. Total out-of-pocket costs by the patient at the time of service. So that's co-pays, co-insurance, deductibles, everything out of pocket. We saw 45% savings in favor of the direct primary care practice. Now we say, okay, that's great. Direct primary care gives you excellent access. You can get in with your doctor when you call. You can do telemedicine with your doctor. We have unlimited visits, no co-pays. There's no barriers. We should be able to show that we reduced emergency room visits and specialty visits, right? How about a 52% reduction in emergency room visits? How about a 60% reduction in specialty spend by the plan? When I have 30 to 45 minutes per visit to spend with my patients, I don't have to refer them out for diabetes management. I don't have to refer them out for high blood pressure. I don't have to refer them out for heart disease management. I can do skin biopsies in my office. I can do cortisone injections. I can splint things. I can do A1Cs in my office. I can do a ton of stuff when I'm not focused on the chart and the computer and the plan, and I'm focused on the patient. So all of my time is dedicated to patient care. So now I funnel all that in, and you should be able to see it. And we're actually now starting to see it. So this, again, almost a 60% reduction in specialty spend. But the interesting thing is that you would think, okay, now we're front loading the primary care, and if we're spending all this money in investment in primary care, you should see a bigger spend on the primary care side. Actually, we saw a 25% lower spend on the primary care side per touch. So I'm going to take this back to Vince and ask for a raise in year number. Actually, we did just get a 3-year contract extension with the hospital, so I think we're doing a pretty good job there. But you look at those numbers, you say, yeah, but that's fine. You guys probably just had a much healthier population. Clearly you're just skimming the cream off the crop. All the sick people clearly with cancer and heart disease, they were staying with their other doctors because they didn't want to switch in the middle of complicated care. Turns out the DPC actually had 21% more chronic disease than the non-DPC group. We had a 20% more disease in our population that we were managing than the non-DPC side, yet we still had. And you can see that was largely driven by metabolic disorders, hypertension, metabolic disorders, high cholesterol, diabetes. But we had almost 3 times the amount of heart disease than the benchmarks. And when I'm showing you these numbers here, that green bar is the national benchmark for what you'd expect to see in that population. And that blue bar is what we actually saw in our DPC population. So when that blue bar is longer than the green bar, we had more disease of that type within our managed population. So again, more metabolic diseases, that means higher risk for cardiovascular disease. And then you look down here again, almost triple the amount of cardiac disease. And you see cancer, like, well, if you had a couple cases of bad cancer in the non-DPC, that's going to skew the numbers. We actually had more than the national benchmarks of cancer within the DPC group. So we were definitely not cherry picking within this population. But when you deep dive down to see, okay, we saw that the vast majority of chronic disease within our population was metabolic disorders, high blood pressure, diabetes. How did we manage those as a practice? Again, we keep a lot of that in-house, so we're not referring it out. Well, if you look here on that column there in the middle, that's the national benchmark for what it costs to manage these conditions, and this is what our actual costs were to manage these conditions. So where the national benchmark was $4 to manage per member per month diabetes, we did it for 72 cents. So we're managing diabetes for 82% less than the national averages. We're managing endocrine and metabolic disorders for almost 80% less than the national benchmarks. Heart disease managing for less than 50% of the national benchmarks. You remember what happened in 2020 and still in 2021? We had this little thing called COVID, infectious diseases. These data are from 2020. I can tell you 2019 numbers look similar. But when you have an infectious disease pandemic that's spreading across the country, it's sure nice if you can manage it for $1.22 per member than $8.81 per member. That's an 86% savings in management of infectious diseases in one of the worst infectious disease crises we've seen in our country in 100 years. Dermatology, we can do biopsies within our office. We don't have to send anybody down to get everything sprayed off and biopsied and come back in 6 weeks. We'll go do it again, come back, we'll do Mohs, we'll take this. We manage our dermatology for 65 cents per member per month compared to the national benchmarks of $4.15 per month. It's an 84% reduction from the national benchmarks. So one of the neat things about this hospital is the way this plan was structured is since the hospital provides all these services already, since the hospital already employs their radiology and the imaging centers, they already have people on staff, they already have a lab, the hospital has incentives to try to get people to have services done within that lab. So the way that the plan design is if you get stuff done in the hospital as an employee of the hospital, there's zero copays, zero deductible, it costs you nothing. You get an MRI, it costs you nothing. You get a CAT scan, it costs you nothing. You get blood work, it costs you nothing. And if you go access primary care, it costs you nothing. So there's some incentives then to try to steer the patients into the hospital to get care because the integral cost for them to treat these patients is very little. And you can see here now comparing DPC versus non-DPC. I showed you the money that was spent, but what you can see here is that 85% on the DPC side, 85 cents of every dollar spent by the plan was spent to the hospital. 85 cents of every dollar this plan spent went from its right pocket to its left pocket. That number was 48% in the non-DPC group. So we were able to steer patients because we understood the plan. We understood how things worked. We weren't trying to send people down the street to my buddy, my friend, I know a guy, this guy I golfed with. So now we look at the results and you say, okay, but did the patients like it? Well, we almost had a 30% year-over-year growth in the DPC. This is a small community. These are healthcare providers. They can scrutinize how healthcare is delivered, I promise you that. And if they think they're getting taken advantage of, or they don't think they're getting good care, they're gonna tell their friends, they're gonna tell the community, and we had almost a 30% year-over-year growth in this. That 20% reduction in premiums that we're seeing on that first year to sort of push or drive the decisions to get them into the DPC, there was zero premium increase in year number 2. So for 20 years, the head of human resources in that hospital would go back to their employees every year and say, our insurance rates went up 15%, and we're gonna take 80%, 20% of that's gonna get passed on to you. And how much of that increase is getting passed on to your employees? 2 years in a row, they didn't have to say that one time to their employees for the first time in 20 years. When we sat down in that room and Carl and the team designed that plan, the stop-loss carrier people were sitting in that room and they're like, you know what, the DPC is the glue that holds this thing together. Because when you talk about zero deductible, zero copays, they're like, holy cow, how in the heck are we gonna control this? And it's gonna be the Wild West of spending. And then they saw that DPC and they're like, oh, that makes sense. We're not gonna have a run on emergency room visits and all this other stuff because we have somebody there that's gonna really manage the care of these patients. And they came in and they gave an initial discount in year number 1 because of the DPC side. And because of the claims history in year number 1, they gave a discount in year number 2. That's the second time in the history of this company that they ever issued a discount on a stop loss in year number 2 because of our excellent claims history. So you might see a little dispute if you look at some public stuff on this number here. I've chosen a conservative number here. So if you look at the 2018 spend by this plan, now this is when they were with UMR, self-funded UMR. The plan spent about $2 million. This is, by the way, these numbers are from the public reporting. This is a public hospital, taxpayer funded. This comes right off of the tax reporting from the hospitals. Public reports, anybody can go to their website and see this information. This is not smoke and mirrors. $2 million in 2018. In 2019, $1.1 million, a savings of $818,000 or a 41.3% reduction in health plan spend. Three months of that, so this is a fiscal year. If you actually look at the calendar year, 3 months of that 2019 spend actually included the UMR and the traditional stuff. So the savings were actually closer to $1.2 million when you actually factor that full calendar year in there, which is more like a 52% reduction in savings. So if you see some discrepancies, that's the difference. But I thought I'm going to pick the conservative number, the number that the whole world can see to validate that. So we all know that CMS has completely adopted this accountable care organization as how they're going to fund healthcare going forward in the future. And so their achievement after 7 years of ACOs, they had 5 years of losses, 1 year of zero basically, and $64 in the last year of per beneficiary savings in the rural accountable care organizations. Rural ACOs underperformed every other ACO. $64 per beneficiary savings. This plan saw $2,420 per beneficiary savings. So I'm going to close with a story of Hannah. Hannah's an employee of the hospital. You'd think, okay, you just got these savings because you just stripped out the care and the benefits and the employees got screwed and you were just the gatekeeper and rationing care. And they must really be pissed working in the system because you stripped away their United Healthcare. They now have no networks because, oh God, I can only go wherever I want to now. And so this is the story of Hannah.
Well, the benefits that we have here at the hospital are more so focused on the employees. The latter part of August, I had a concern regarding my neck, and I went in to see my primary care, listened to my concerns, and he recommended certain protocols. It was my choice of what I wanted to do. You would think with the specialist, the appointments are so far out. Within maybe 3 weeks from seeing my primary care, having my test done, getting my results, finding out that I needed to have a biopsy done. Biopsy comes back, positive for cancer on the left side, and a week later, I was headed into surgery. As of today, all is well. I have gone through the process, an estimated cost of $42,000. What did I pay? Absolutely nothing. So before, I was paying all that money on my premium, and I never used the plan because I was reluctant. Because if I have this copay, I'm going to have this deductible. We don't have those issues. Every concern I've had since day one of this plan, I have addressed and have taken care of this year. And I've paid absolutely nothing out of pocket. And we deserve that. I know I do.
So thank you. I think we still have plenty of time for questions, so I'll go ahead and have a seat and open it up, and we'll be passing around some microphones. Please make sure that you speak into the microphone for your questions so that people online can actually hear the questions and answers, please.
Okay, Lee, thank you, first of all. Those data are just so fantastic, and actually I've seen a lot of comparison DPC data, but there's nothing like this because it's actually at a hospital. It's people who know healthcare can really choose wisely for themselves, so it takes away all the stuff about uninformed healthcare consumers and stuff. My question is, people in the room, I'm a healthcare economist, so I'm coming at this from incentives and stuff like that. And one of the things I've really come away from this weekend is this idea that the best possible, even if the only thing you care about is cost control, the best possible gatekeeper is actually a DPC physician that has the time to actually take care of their patient's health, right? You don't need all the speed bumps necessarily about deductibles and copays and this and stuff, which is where most economists are stuck, I think. If someone were to, and this is completely unfair, if someone were to look at these data and say, holy shit, that's amazing, where could you get me another 20% savings? Where would that be? Or what else could be done here, even if someone didn't look at these and have their mind boggled? Like, if we're going to squeeze the grape in a good way, we want to keep people healthy and everything else, is there anything else that could be done beyond this if someone wanted to get really greedy?
Yeah, I think the where you could really squeeze the grape is on the pharmacy side of this. Because, frankly, this hospital is a rural hospital. They could become their own pharmacy. They can put a dispensary for their employees in there. Right now we're using local pharmacies and retail pharmacies. But you could definitely, just like the DPC practices, some of the small ones that do direct dispensing, the hospital, because they're a rural hospital, accesses actually cut rate prices on meds. So you could definitely do this. And so how could you grow it then beyond that? So let's not talk about savings. Let's talk about scaling, because I'm a bit of a purist. I think the scale of this is one doctor, one patient. And so that's the scale of primary care in my mind. one of the great things with this community is if we're trying to keep the healthcare dollars local, we should be able to extrapolate this and say, okay, let's go ahead and replicate this with the county, the school board, the police department, the fire department. And that's kind of where we're heading next. I mean, those are our next steps. We're already engaging in conversations. Again, stop spending or sending all the money from these poor rural communities up to Wall Street. Let's go ahead and relocalize those dollars, reinvest them in the community, because a $1.2 million savings in DeSoto County, Florida, is mind-blowing. And what that's allowed them to do is turn that money around and hire the first full-time general surgeon in the history of that rural community.
Can I lean into that just for a second? And in addition, I mean, tremendous results, right? The proof's right there in the pudding. It really is. One thing that we talk about, and yes, the direct primary care doctor is well situated to really play that quarterback role at the center of that. But one thing we run into, even when you have even direct care specialists that are then taking referrals, there are ways to even lean into that model and say, okay, how can we change that interaction to avoid even a high-cost event happening? And so we've talked with, for instance, orthopedics, who are willing to provide a very low-cost consult at the behest of the direct primary care doctor on behalf of a patient. And so even like preempt something that would be a good outcome, which I think you're saying, look, it's a great outcome on the board. How do we get even better? Always improving. Well, a good outcome is referring that patient to a direct care orthopedist. An even better outcome is providing kind of a half measure in between, providing that sort of a consult before you even make that referral, and perhaps even squeezing more savings by avoiding that.
Yeah, I mean, the other thing is Lee's data, and we've got data that's similar. The Society of Actuaries have produced similar data too, so it's out there. It's real. That's usually like 1 year of data. So Lee's going to do a way better job controlling the patient's diabetes, and so the real savings is in the long run. Okay, it's shocking that we can even find short-run savings, but we can. It's amazing. But the real savings is downstream. We have a direct care pharmacy, so we own a pharmacy. It's part of our package, and then we just sell the patients their meds at cost. So a Z-Pak's $2, a month of Prozac 85 cents. So there's savings there too, and the more people in the healthcare system that adopt a model that cuts out middlemen, the more savings.
We have an online question. Can FreedomDocs provide prospective customers comparative financial pro forma, including all FH costs, fees, etc., to measure ROI, hard, soft value of your services versus DIY?
Better you than me.
Great question. Long question, short answer, absolutely yes.
Okay.
That's part and parcel to the deliverable. Any business, you should never step into a business and commit yourself, time, money, resources, put that strain on yourself and your family unless you have a clear path to success. And that involves pre-scripting the entire financial startup of the business, and then your run rate to the point you reach break even, and then you finally fill your panel. Absolutely, yes.
I was just going to personally, from the bottom of my heart, thank Dr. Gross just because of his work he's done nationally. If y'all follow everything this guy does, the time away from his family, the commitment he's made to make a change. So I just want to, of course, enjoy working with you, and it's great presentation. Thanks for all that you do.
Thanks, Carl. There's a question in the back there.
Yeah, this is Lee Lewis from the Health Transformation Alliance. Question for you is, if it wasn't you and Carl, and we chose a direct primary care clinic out of a hat and put them into that same situation with that hospital, would we have gotten the same return? Would the return be basically identical, or is there something different and special that you are doing that is delivering outsized results?
Yeah, I think you'd still see the savings. They may not be quite so dramatic. One of the questions I get a lot is, okay, well, that's just capitation. Aren't you just capitating primary care? We're just going to go ahead and fix the cost of primary care. And my standard response to that is, if you think that taking the cheapest thing in healthcare and fixing that price is fixing healthcare, it's going to solve the problems, you're absolutely wrong. the model itself dynamically changes the fundamental interaction between the doctor and patient and realigns the incentives so that they're all moving in the right direction. So, the model itself, I think, is a better mousetrap than that. But to your point, one of the beautiful things about direct primary care is it shines a bright spotlight on that primary care physician. And so that doctor shines. But if that's not a good doctor, you're also going to shine a bright spotlight on the deficiencies and the weaknesses within that practice, on that practice delivery model, which is it may not play out the same in every single practice, but that's just the nature of variability. And that's, again, one of the beauties of the free market is, you have two practices side by side. One gets one result, one gets another. Let's compete on price and quality.
And I'm going to slightly disagree with Lee. I think yes. I think if you capitate primary care, it changes the incentive structure and it makes the average primary care physician, NP, PA, whoever it is, act with better incentives and it lowers costs. We're going to admit that Lee is special, and in a good way special, and that his results are going to be amazing. And there are going to be people who do a little better and a little worse. But yeah, you capitate primary care, the world gets better.
Wouldn't you guys both agree, though, that there are, at this point, emerging, call them lowest common denominators within the field? And again, market dictated, here's what the consumer expects from DPC. I mean,
I'm not sure whether yet. I
we
think we're, the question that I have is, are we still in the innovator stage of your curve, or are we in the early adopters? I think we're probably closer to the innovator section of that. And so I'm not sure we have a clear definition right now of what DPC is. There's a gray and blurry line between concierge medicine and direct primary care, and there's corporate DPC and independent DPC. There's hybrid DPC. And they're not all the same. And they're not going to achieve necessarily the same results. So you have a hybrid that's part direct primary care, part fee for service. You can't serve two masters. I mean, it's a complete cultural change within the practice, and how your staff interacts and how they deal with patient encounters, and shifting the philosophy of your practice team being the gatekeepers from patients getting to the doctor, and the philosophy of getting every single patient on the schedule, to your doctor is available now. You can see you today, you can hop on the phone today. And if you're trying to do both within the same physical structure, there's no employee that's good enough. Even your best employees cannot manage to do that well. And so, we've seen a million ways to do this wrong, and there's a few ways to do it right. And the market will sort this out. I think we're very early in the process of it, which is, again, one reason why I think we have to be very careful as to how we proceed from here, because if we're putting if we're building the foundation of this structure, it needs to be sound and solid. And this is probably the most important phase of the development of this practice model.
So this question, I have two questions. They're for all three. One of them is, I know there's a huge issue in just recruiting rural doctors, and I wonder if you guys have any insights onto how maybe DPC might really make doctors actually want to practice rural, or if it's going to have to be a telemedicine thing. And then my second one is, most of my female friends, and me included, we don't have primary care doctors. We have our OBGs, and they're the people we've seen our entire lives. Why is it so difficult to find DPC OBGs? It's really hard, and maybe it's. I just have no idea. I'm not in the medical field. I don't know if you could speak to that, but it's so difficult. Traveling with a newborn is its own set of challenges. So as much as I would love to go to Oklahoma, it's like, why is that so hard? I just don't understand it. So those are my two questions.
Mind if I jump in?
Yeah, go ahead.
To tackle the rural question first, Kelly, certainly, and I'm going to take it from a business standpoint, right? Had tremendous meetings with folks that are focused on the rural economic development side of things, right? And they say, hey, 10 years ago, we used to get questions related to tax benefits and incentives. Why should I relocate my company here to this rural town, right? Now it's all about quality of life. Today, those conversations are housing, schools, and medical care. So there's a tremendous need, and there's a drive to bring medical professionals back to these communities. I think the cool answer and why we were having that conversation is that many times people think that these smaller markets just cannot support freestanding doctors and hospitals and clinics, right? What DPC does is it actually shrinks your patient panel to the point where you can not only survive, but thrive in smaller markets. And some of the most successful practices that we've seen are not in the major metropolitan areas because there's a lot of different choices there for consumers. You go to a small town and there's nothing in the way of choice. So everybody wants to go to that particular clinic that fires up, right? The other part of it being that it's a much leaner model, lower overhead. That's why it can thrive on a smaller customer base. So I think it is a mechanism by which rural health can be rejuvenated. And I know there are some tailwinds in the form of rural economic developers and even policymakers that see this as a way to bring that back into those communities.
And I know we all have a lot to add to that. And unfortunately, we are out of time for the panel. I know these folks will stick around and answer questions. I'm here all night tonight, not leaving until tomorrow morning. So if anyone's around and wants to talk, I'm happy to entertain questions. You guys are awesome. Thanks. It's been a pleasure to work with you.
Thanks. Thank you.